Welcome. Today, we will explore the definitive clinical guide to identifying, diagnosing, and managing cow's milk protein allergy in pediatric populations. Synthesized from the Canadian Pediatric Society guidelines and comprehensive clinical reviews, this session provides evidence-based clarity for daily practice. At its core, CMPA represents an immune-mediated Th1 to Th2 balance shift. It is an adverse reaction triggered by proteins in cow's milk and affects between 2.0% to 7.5% of infants globally, making it the single leading cause of food allergy in children under 3 years old. The culprits belong to two main protein fractions: casein, making up 76% to 86% of milk protein, which is highly allergenic and heat-resistant, and whey, making up 14% to 24%, containing alpha-lactalbumin and beta-lactoglobulin, which can sometimes be denatured by heat. A critical first step is distinguishing immune-mediated CMPA from non-immunologic cow's milk intolerance. CMPA is driven by immune pathways, IgE, non-IgE, or mixed, peaks early between 4 to 6 months of age, and causes multisystemic involvement. In contrast, CMI is an enzymatic deficiency, a lack of lactase, that is exceptionally rare in infancy, typically appearing in late childhood or adulthood, and is strictly localized to the GI tract. What drives allergy risk? 3 main factors. First, genetic predisposition. A family history of atopy significantly elevates risk and is linked to Illinois 10 gene variations. Second, delivery mode. C-sections bypass exposure to maternal vaginal microbiota, delaying the immune system shift from fetal Th2 dominance to a balanced Th1 response. Third, feeding practices. While exclusive breastfeeding for 4 to 6 months offers protection, CMPA still occurs in up to 0.5% of exclusively breastfed infants via minor dietary protein transmission into human milk. When exposed to cow's milk protein, adverse reactions classify into 3 distinct immune pathways. 1. IgE-mediated, rapid in onset, manifesting as acute urticaria, angioedema, wheezing, or anaphylaxis. 2. Non-IgE or cell-mediated, delayed GI manifestations including FPIAP, FPE, and FPIES. 3. Mixed IgE and non-IgE, characterized by organ eosinophilic infiltration, seen in conditions like eosinophilic esophagitis. CMPA manifests across multiple organ systems. In the digestive system, look out for vomiting, chronic diarrhea, colic, and blood or mucus-streaked stools. On the integumentary system, eczema and urticaria are primary indicators during the first year of life. In the respiratory system, chronic coughing, wheezing, and allergic rhinitis often emerge as the allergic march progresses. Keep in mind nonspecific systemic effects like thrombocytosis, poor iron absorption, and vitamin D deficiency. Non-IgE reactions operate along a spectrum. On the mild to moderate end, we have food protein-induced allergic proctocolitis, typically presenting in a well-appearing infant between 2 to 8 weeks of life with bloody or mucoid stools. It resolves rapidly within 3 to 14 days of maternal dietary elimination without invasive testing. On the severe end, food protein-induced enteropathy involves T-cell-mediated jejunal villus atrophy leading to malabsorption, chronic diarrhea, and failure to thrive, requiring formal endoscopic biopsy for diagnosis. We must highlight food protein-induced enterocolitis syndrome as a true medical emergency. Characterized by repetitive, profound emesis occurring 1 to 4 hours post-ingestion, FPIES is easily misdiagnosed as acute sepsis or gastroenteritis. In 15% of infants, it rapidly progresses to hypovolemic shock, severe dehydration, hypothermia, and methemoglobinemia. Immediate aggressive fluid resuscitation, steroids, furondansetron, and absolute strict avoidance of all dairy forms are mandatory. The diagnostic pathway relies on a clinical sequence. Step 1. Detailed clinical history. Step 2. A 2 to 4 week diagnostic elimination diet. Step 3. The oral food challenge, which remains the undisputed gold standard to confirm diagnosis or confirm outgrown tolerance. Note that IgE testing helps confirm immediate reactions but is typically negative in cell-mediated CMPA. Recent findings show specific IgE levels between 0.1 and 0.35 KIU/Rl may still carry clinical significance. A major clinical warning: avoid unproven diagnostic panels. Food-specific IgG testing is non-evidence-based. IgG presence reflects exposure, not allergy. Relying on IgG panels leads to severe overdiagnosis, forcing families into unnecessary, expensive specialized formulas and long-term elimination diets that compromise the infant's nutritional status and growth. How do we manage the breastfed infant with CMPA? First-line strategy: preserve breastfeeding. Implement an empiric maternal dietary elimination of both dairy and soy for 2 to 4 weeks. Ensure the mother receives nutritional guidance and mandatory daily supplementation with 500 mg calcium twice daily and vitamin D. Only in rare, refractory cases where symptoms persist despite strict elimination should we consider transitioning to an extensively hydrolyzed formula. For formula-fed infants, adhere strictly to the hydrolyzed formula hierarchy. First line: extensively hydrolyzed formula, effective in over 90% of cases. Second line: amino acid formula, reserved for the under 10% who fail extensively hydrolyzed formula after 2 to 4 weeks or present with severe FPIES and failure to thrive. Strictly avoid mammalian milk options like goat or sheep milk due to high cross-reactivity, and avoid soy formula under 6 months of age due to cross-sensitization risks. Emerging microbiome modulation strategies show that infants with CMPA exhibit gut dysbiosis. Supplementing extensively hydrolyzed formulas with specific probiotics, such as Lactobacillus rhamnosus GG or Bifidobacterium lactis, promotes gut barrier repair, expands short-chain fatty acid butyrate-producing bacteria, accelerates immune tolerance, and achieves higher rates of natural tolerance by 3 years of age. The natural history of CMPA carries a favorable outcome for most children. 50% outgrow it by age 1, 75% by age 3, and over 90% achieve tolerance by age 6. However, CMPA often acts as the entry point to the atopic march. Early food allergy significantly increases the risk of subsequent respiratory allergies. Roughly 41% of children with CMPA go on to develop asthma, and 31% develop allergic rhinitis or conjunctivitis. To conclude, remember our 5 core principles. 1. Differentiate CMPA from enzymatic milk intolerance. 2. Recognize acute FPIES as a true medical emergency. 3. Rely on clinical challenge over unproven IgG panels. 4. Protect and support breastfeeding with targeted maternal elimination. 5. Follow the formula hierarchy, extensively hydrolyzed formula first, reserving amino acid formula for severe, refractory cases. Thank you for your time.